Hi, everyone, and welcome to this week's What's Up Doc series. If your limb is on deck for amputation, your leg is on deck for amputation, it's worth considering a second opinion, especially if your life isn't on the line, a very important determinant. You need to ask your doctor, hey, if I don't let you take my limb, is my life in jeopardy? And if they say no, that you have some time, it's really important to get a second opinion. Why, you might ask? Different doctors, different tools, different techniques. And some just don't even know that there might be something new and something different out there. But if you take an opportunity to take a step back and get that second opinion and explore other options with a different doctor, maybe even in a different facility, your limb and ultimately your life in the long run might be saved. But it's really important that you're here for this discussion today and other discussions that we have right here on our YouTube channel, youtube.com/at the way to my heart. Make sure you subscribe to our channel because we bring you the new cutting edge tools and techniques from amazing cutting edge doctors like Dr. John Rundback, interventional radiologist with American Endovascular in New Jersey. And so, hi, Dr. Rundback. Thank you so much for being here. Thank you for bringing us a brand new technique to a Hail Mary limb preservation technique known as deep vein arterialization. So thank you so much for being here.
Great, Kim. Thank you so much. And thank you to the whole community that we are live streaming to. I mean, Kim has been such a powerful voice in getting this message out that often you don't need to lose your leg, even if you might have been told that that is the only option. And increasingly, like Kim said, there are physicians who have particular interest in limb salvage procedures and access to strategies and now research tools like we'll be talking about tonight that offer an opportunity to save the limb, even in the most dire circumstances. And, we can't get this message out enough. I mean, I jokingly say to our media people here that we need a similarly graphic advertisement that the smoking people did. And ours would say, don't get amputated. And maybe it has to show some graphic, pictures. But the point is that I don't think that message gets out enough to individuals.
No, and you do have quite a few doctors. There is one school of thought that amputation is purely treatment. It's they really feel like it's the best option for these patients. If they can't do anything to save the limb, then nothing should be done. Why delay the inevitable? I've actually had doctors tell me this. Why delay the inevitable? You don't want to be sitting here over the next year doing wound care after wound care and having a revolving door of procedures to get yourself back on your feet where there's no guarantee. You should just get her done, cut your losses, cut that leg off, and move forward in your life, get your prosthetic, and actually just go through rehab and get back to work. The problem that we have in this country, though, and I don't know about other countries, but in the United States, more than 60% of people who have been amputated don't even have a prosthetic. And so to say that everyone's going to get their life back, it's the best treatment for everybody is just not the right thing. And patients tell me every single day that they would rather literally have a procedure, a revolving door of procedures, to walk to live another day and live to walk another day. They want their 2 feet. And in fact, Dr. Runback, to continue my monologue here, is we have one patient who joins us a lot. Her name is Marsha B. And she said to me today, I don't mind my toe being cut off, but I have to tell you that if it comes down to my leg, put me on palliative care. I'd rather die. And I hear this often, and it's really sad. So it's amazing when you have doctors like you that are willing to take that extra step and say, if amputation is on the line, why not try?
Yeah, and you bring up a good point that you'll get physicians who, I'm sure out of their firm belief will tell a patient that the best option and the most expeditious solution is a major amputation. But I can tell you that my patients and the patients of my colleagues who work very closely on limb salvage, advanced limb salvage procedures, frequently share that they're very glad they went through this and saved their limb. Because look, I don't have to tell you, life has its challenges, and healthcare is one of them. But we can get you through this. It may take 6 months, it may take 4 months, whatever it might be. At the end of the day, to have a ambulatory foot surface, be able to get back to normal quality of life, to have the kind of the perception of being normal and active and fit, I think makes all the difference. And like you said, it's a perfectly good idea if you can get a prosthetic, get fit for a prosthetic, and then be able to adapt to a prosthetic, but that's not the case. And amputation itself is traumatic, not just emotionally and physically traumatic, but it's traumatic in terms of overall risk to your well-being and survival. So, and we know, I'm sure you've talked about that data, that if you have a major amputation, you have a considerably higher risk of dying within the next year or two. So we do want to avoid that at all costs. And that's why we're involved in a lot of these initiatives and work with a lot of companies to develop novel therapies which can prevent amputation. And we're better now than we were 5 years ago, certainly 10 years ago, but I'm not sure that awareness has spread yet throughout all communities. That's why what you do is so important.
Yeah, and we just had another patient today. I was so proud of her that she ended up in her local community hospital in the emergency room, and she went to her normal vascular surgeon that has frontline therapy, did a bypass, fempop bypass. Then that failed within a few months, and went ahead and redid the fempop bypass. And that failed within a few months, and never even tried an endovascular approach. Finally went in, did an endovascular approach, wasn't really that successful with that, probably doesn't do it very often. And so she was back to square one. And she went to the emergency room with an infection creeping up her leg. And she said to this doctor, I talked to Kim with the Global PAD Association, and I learned that there were multiple ways that you can do this. Can you try? Please, I will pray with you right now that God will work through your hands if you'll at least try. He did it. He came back in tears and he was like, I did it. I opened up your arteries below your knee. I opened up your knee. And it was amazing. And so we're going to start to see more and more of this. If it's not coming from the top down, it's going to come like the Susan G. Komen Foundation from the bottom up. And it's going to be patients that are going to their doctors and saying, hey, I expect more. And it's doctors like you that are coming on here to offer the patients this critical information that they can use to better advocate for themselves.
Yeah, no, I couldn't agree with you enough. We need patients to be aware of their options, and patients' family members, when the patient's unable to do so, to sort of step up. We always say the oldest daughter is the greatest, advocate, and the greatest person who finds the information for their loved ones. And we have to sort of get that message out because, fundamentally, I do like to believe that every doctor feels that they are as good or better than everyone else. I mean, it's hard to practice otherwise, right? And sometimes you sort of kind of get into a pattern of practice and you're not necessarily aware of all the, other possibilities that exist outside that pattern. And that's why often you have to rely on the patients themselves to find this. We see it in cancer therapies, certainly, in other areas as well. And I think it's increasingly true in vascular work that, for patients with complex patterns of blockage, particularly below their knee and into their foot, not everyone has the exposure or experience to do these cases, no matter how good they think they might be.
So let's get into the topic du jour, the new cutting edge approach to that Hail Mary procedure that, was approved, a couple of years ago for deep vein arterialization with a device called LimFlow. And LimFlow was a technique and was a device that was used in a technique called deep vein arterialization. I think they call it something else now, TVAR or something like that.
Transcatheter arterialization of the deep veins. Yep.
Yes, there you go. Would you mind telling us, first of all, talk about deep vein arterialization, and then we'll talk about the pros, the cons, because I know the reason I'm wondering with you getting involved, LimFlow wasn't available outside the hospitals. And I know why they went after the hospitals. They went after the hospitals because that's where a lot of the amputations were occurring. So they started there in marketing, but they weren't marketing to the office-based labs and ambulatory surgical centers. And so you guys really needed an option other than just off the shelf. So I imagine that's kind of where we're going with this conversation. But
Sure.
first, talk about deep vein arterialization and just give us the lowdown, the basics for everybody.
Sure. So I'll give you a magical mystery tour, if you will, the history of all this. So, clearly, we've been doing, revascularization of blocked arteries below the knee and into the foot for, well, I've been doing it for 30 years. But it's in the last 10 years or last decade, we've developed some tools that are small enough to treat some of these and some techniques, such as puncturing into the arteries in the feet to cross blockages backwards rather than forwards, that are to move the bar forward. However, a sizable percent of diabetics, chronic kidney disease patients, and other patients have blockages that just are not reconstructible. The arteries are too small. They no longer are arteries. What I like to say is that once was a river is now a dry riverbed filled with rocks, and it can't be traversed. And that's considered non-reconstructible or no option disease. And in our practice, which is a limb salvage practice, that's almost 20% of our population who by virtue of its name alone, we could offer very little for. Deep venous arterialization is an interesting technique. I've been doing deep venous arterialization for 6 years. The limb flow system, and I'll get around to that in a moment, was actually just approved after clinical trials this past year. So it's now only commercially available in the last 6 months or so. And just now actually got a reimbursement, which unfortunately in this country is so relevant because we get technologies that we can use before they're actually paid for, which means we can't really use them, unfortunately. But now it's paid for, but still a lot of hurdles bringing it in. So the idea between deep venous arterialization is actually pretty amazing, to tell you the truth. So when people get diabetes and chronic kidney disease and other conditions which block their arteries, in most cases, not all, but in most cases, the veins are preserved. So what's the difference? So the arteries deliver blood throughout your body from your heart. They're pumping under high blood pressure throughout your body and to your feet. The veins return blood back to your heart, and it's a low pressure system. And what we do in deep venous arterialization is we connect the arteries just above the point of blockage to the veins to now get the vein to the liver blood rather than return blood. And you have to sort of do some modifications and block the pathways that we don't want, and develop the pathways that we want to help in a targeted way get those veins down to the liver blood flow down to the wounds and allow healing. And we've had results nothing short of miraculous. I mean, really nothing short of miraculous, and you need good wound care with this and a good podiatrist and a good team that takes care of it. But absolutely unbelievable results. We've published our results, and our results using off-the-shelf devices, just tools we had for other purposes that we fit for this. We had limb salvage, prevention of major amputation in almost 3/4 of the cases. That's the same thing that the limb flow system showed. But we found, and we published this as well, that the way we connect the artery to the vein now is by putting a stent graft in, sort of like think of a bypass that's supported by a metal scaffold, and it springs open. So you thread it through the artery, across this connection you've made between the artery and vein, and sort of spring this thing open. And it's covered with a bypass material to now detour blood flow from the artery into the vein. But we published our results about patterns of failure. It is often around that graft. Your body wasn't made to have this self-expanding metal object in your lower legs, which, by the way, was not really sized for the appropriate size of those small arteries and veins in the leg. So it was kind of constantly pushing out and constantly causing irritation and inflammation. That was around that graft was a common cause of failure. So certainly the results are very good, but we've been looking for other techniques to create and maintain a durable connection between the artery and the vein to allow the veins to deliver blood flow to the feet without that stent or that graft in location. And that's what the Avera thing is. Now, I actually have a list of sites, and I'll share with you to put on the community at some point a list of all the sites involved in this particular trial.
Yes, please.
We are looking obviously to get patients enrolled so we can help to continue to further the science around this practice, because we really think that we're onto something here that we can really make a difference in people's lives and prevent amputations. Right now, a lot of trials being run through the ORCA network. So ORCA network's just it's called Outpatient Research Cardiovascular Alliance. It has nothing to do with the whale. Originally, our logo had a whale, but we thought that was a little bit too, I don't know, cute, and we got rid of the whale in the logo. This is a collection of ambulatory surgery centers and outpatient labs or office-based laboratories. And I think that's important because as your community well knows, many of these procedures are done in the hospital. And for the patient experience, the hospital is not always the best environment. So we're very excited to have the opportunity to do some of these complex procedures in an outpatient environment in office-based laboratories and ambulatory surgery centers where everyone's focused on just this. This is just what we do. We're not, doing 1,000 other things. There's no distractions. There's no emergencies that are arising in the hospital that, might take priority over you. So we've been able to bring this technology. The company that developed this technology is called Avira. And I asked them if they have a landing page. They don't yet have a website, but based upon my informing them, I'm going to be speaking today. They're going to be developing one. So
Always about inspiring the change you want to see.
right. So, but you can take the name AVEERA, and the trial is called the Boomerang trial. And see, I don't know, is it work to share or is it not work to share? Let's see.
It works to share.
Let's see if I can share. So I know they were nice enough to send me a picture. Let's see. That's the Zoom picture. So you'll pardon me. I'm a doctor, but not super great at the IT tech. Here we go. So here's a picture of this. Hopefully this will pop up. Can you see that?
Yes.
Okay. So this is a stentless DVA. And let me just enlarge that a little bit. So here's the artery, which we've come to from entering the artery by the hip. Here's the vein, which we've entered by putting a little needle, no surgery, no cutting. It's done with some moderate sedation and local anesthetic, putting an IV or a needle into the vein in the foot. And right here, you can see where this device has basically come from both sides and created a fused connection. This is a welded connection between the artery and the vein. To get the artery, which blocks at this point right there, the artery should be going down, to now connect to the vein. And the end result is now you get this vein delivering forward flow down into the foot. And if I do this video and see how brisk this flow is. So this is a deep venous arterialization or a transcatheter arterialization of deep veins. And the only difference between this and what you might see in limb flow, let me turn that off, is that there's no metal lining all this, a big clunky, metallic scaffold. This is just done this way. And that's nice because this allows the arteries and veins to preserve their natural qualities and heal, rather than trying to kind of work around by putting this sort of complex bypass and metal material. So that's what it looks like. And I'll leave that up for a minute, during our conversation. But so we're very, very excited about this. I did a bunch of these cases down in Mexico where we did it. The results have been fabulous. And now we've done 5 at our site. And I'll send you guys the list of active sites, which you can put up on the site, but it's around the country. So it's not like you all have to come to New Jersey to see me. I'm obviously more than happy to care for anybody or speak to anybody in this community who might have need and want to talk. Feel free. You can reach me through Kim, or she's got my contact up. But you don't necessarily have to travel to New Jersey, even though it's the Garden State. There are sites really around the country now. I'm looking 1, 2, 3, 4, 5, 6, 7, 8, 9 sites, 5 more coming on board. So there'll be 14 places around the country participating in this trial, which is places in, I'm looking at the list. I don't have all the locations, just the name, but Houston, I see, Portland, I see, a couple in New Jersey, in Maryland, in Florida, in Denver. I don't know where that went. Oh, North Carolina. So, certainly they're going to be great physicians. I mean, any of the physicians who are participating in this, I'm actually the national principal investigator on the trial. So the physicians who are selected are all physicians who we consider in our own community to be the best of the best.
So I have a couple questions coming in. We have Juanita that says that she had the limb flow procedure before. She wonders if she would still be a candidate if that potentially needs to be redone and she ends up with a desert foot. Then would this be an option for her?
Yeah, once that graft is in place from the limb flow, then you have to focus on keeping that one open, at least until the wound heals. We've actually working on another paper looking at the healing process after limb flow. which consists of two processes we call maturation and conversion. And what happens is almost miraculous, because over time, new vessels form, and that even if the limb flow or the DVA, or in this case, the boomerang DVA closes, often people get long-term benefit because you've created this robust network of new blood vessels. So to answer your question, I didn't hear her name. If the limb flow, okay, if the limb flow is closing and your wound's not yet healed, and we published this article as well, you just have to keep it open as much as you can until the wound heals. And after that, even if it closes, generally you've gone through that maturation conversion and you don't necessarily need anything more.
And Marcia wants to know what type of patient this is actually good for. So who is this indicated for? And that's especially important for the trial in particular.
Yeah, so the trial's fairly open. I mean, anybody who's got a wound. And unlike many trials, which don't include individuals with the most severe wounds, this trial does. So even if you have a very bad wound, now it's got to be relatively stable. Now, that being said, we can still do a DVA if you're unstable, but be on the trial. They don't want patients who are rapidly deteriorating because the process in this country is you have to show reasonably good results in order to get approval and payment. So if you take people who are rapidly deteriorating, do superimposed infections and things like that, it just can result in bad outcomes of the trial and limit the availability of this technology down the line. But if you have a wound, if it's relatively stable of any severity, and you've had some sort of imaging, or you get imaging that shows that you have that desert foot that you referred to, where you have blockage of the blood flow into the foot or down to the wound. It doesn't have to be all the arteries blocked, it just has to be the wound arteries that are blocked. Then you would be a candidate.
Can you walk us through how this fusion works? I know it's a little geeky, but I'm fascinated by it because I just watched my very first P-TAB with one of your friends, Dr. James Joy, out here in Silicon Valley. And I watched him do it. And it was just amazing, how they went from the artery to the vein. And the P-TAB procedure is where they do, they use a vein, but they hijack half the vein. They thread a covered stent from the artery to the vein to reroute blood flow, and they thread the stent all the way through and bring it back into the artery below the blockage. And it was fascinating to me how they would poke through the artery into the vein. I didn't realize how close they were together. And so when they were pumping up the balloon in between, they were I couldn't believe how wide they were able to pump the balloon and open up that artery in the vein. And then they would put the stent across. With this, are you just kind of just bringing them together and is there a certain material that's on that?
By way of colorful analogy, so that detour procedure that you're referring to is for patients with blockages in the arteries between the hip and knee. This is for people with blockages below the knee and into the foot. So that's an interesting procedure. The analogy of that detour is you have a northbound 2-lane highway and a southbound 2-lane highway, and the southbound is completely blocked. So what you do is you create a tunnel which goes from that southbound highway above the blockage, takes up one lane of the two-lane northbound highway, and then goes back into the southbound highway below the blockage. So that northbound now has one lane that's open and one lane that's a tunnel that's kind of allowing blood flow in the other direction, or in that case, traffic in the other direction. In this, it's one direction. We've actually done some of the similar sort of procedures below the knee, artery into vein and vein into artery, but that's much less common. This is radio frequency, which fuses this. So radio frequency is used for a lot of technologies, but it's got a device goes through and sits in the artery, and then a plate comes up and you turn it on, it kind of fuses together. Actually, it's got a number. It closes as it fuses the artery and creates a circular ring. And what's nice about this too is this is so stable, you can immediately, if you say it's not open enough, you can just go and balloon and stretch it. It's fused. It can't be disrupted, which is really, really, really nice. And once you create that, now, what you can't see here is the natural tendency when you first create this is that the blood will come to the artery, the vein. Since veins flow back to the heart, to short circuit. So as part of this procedure already done here is we just put a little plug right there. So we block the artery from short circuiting and flowing back through the vein to the heart, and instead drive it downstream. And that's some of the fancy footwork, if you pardon the pun, that we do during this procedure to help not just create this connection, but to direct blood flow down into the foot and down to the wound. So it's radio frequency that's creating that fusion, that welded connection that you refer to.
Right, but they have to actually puncture the artery, right? First and the vein in order to kind of create that
Yeah,
path.
so get at the artery by the hip, get at the vein by the foot, and you kind of get them aligned, right? And then there's a couple of ways to connect the artery to vein, and every doctor does it differently. There are devices that have needles, like you referred to, which poke out of the artery, and you can make a target in the vein, either a little snare you can poke into or a balloon that you can puncture, so we use those devices. You could, once you have a balloon in the artery in the vein or snare just from the outside, puncture through both of them, boom, boom, and then kind of pull them out so you're distracted on both ends, and you get your wire which goes from the hip through this connection and out the foot in the vein. So there are different ways to create the connection, but once you create it, connection in the artery and vein, it's just a little wire connection. There's no flow in it. So either you have to balloon it and put a stent, or do, in this case, a fused or welded boomerang connection with the Avira device.
And so what resistance do you feel like you're going to face in bringing this one to market?
I don't think it'll be too bad. I mean, only resistance we'll have will be if the results turn out to be as favorable as we saw in Mexico, and as we have seen with the lymph flow system, and we've seen with our off-the-shelf device. We're believing this should be have better results, particularly in terms of the need to kind of repeat the intervention and do that close surveillance, because what happens when you don't put a foreign object in a foreign body is that the veins and the arteries have normal, it's called endothelium. It's the inner lining of the blood vessel. And that allows normal vessel healing, without excessive scar tissue buildup. And that's what happens when you have a graft or a stent, you get a lot of excessive scar tissue buildup. And so we're hoping this will be better. The only hurdle will be getting through the trial, 105 patients. So we have ways to go. We just started. And, obviously getting the results that we're anticipating that we'll see.
And this is a process. So, it's something that people can participate in now, but it takes a long time for it to get clearance. Do you expect that this is going to take a couple years to get this trial done?
Yeah, which is why it's so important to talk about the trial, because there are people now who have been told they have no option, who
Yeah.
are willing to participate in a clinical trial to get, access to this. I mean, let's say, for instance, in 5 years, this is the treatment for patients who have no other alternative. How great would it to have had access to this technology, when you needed it and before it was otherwise available. And that's, the beauty of trials. You are taking a risk with a trial, but, the interesting thing about these trials is the risk you're taking is that it won't work and you'll end up with an amputation, which is what unfortunately individuals are facing anyway. So, the downside is what otherwise would have been the results. But you're right. I think this trial will probably enroll by, if we're lucky, by the end of 2025. I mean, with your help and the help of this community, maybe sooner. As research in general is an interesting thing. And it's not just a medicine, but everything. Everyone wants to know the results, but people rarely want to participate. And obviously that's a paradox. That can't work that way. We need people to participate and understand that not only are they potentially helping themselves or their loved ones, but they are contributing in a much bigger way to make a difference in how we can care for so many more people down the line. And that's what the value is.
People are, though, they're going to weigh and they're going to say, well, why would I do this trial when I could find a doctor that has lymph flow?
Yeah, so I'll tell you that. So I think in the end of the day, there'll probably be both technologies that work. And this is how I see it. If you can only get the artery open a little bit into the calf, you have a long way to go. You're probably better off with a lymph flow, because you have a long way you have to connect from the artery down to the veins in the foot. You make a connection high, but if you just did this, you'd fill up so many veins that it'd be very hard to steer the blood flow into the foot. However, when you can open up the artery down to the lower calf, I think this is going to be better, because you can avoid the problems associated with the stents and the grafts, particularly in the vessels lower down. You can avoid damaging the arteries and veins that were undamaged, as part of the process. And I think you probably get better flow and less need for repeated intervention. So I think there'll be a role for both. I think, in my opinion, at this point, and we're still learning. After 6 years, I'm still learning. Oh, I take that back. After almost 40 years of medicine, I'm still learning. But I think that's going to, in the end of the day, be what it is. If And it may be, let's say somebody from this community lives down the street and is facing this problem and came to me for the trial. I very well might look at it and say, you know something, I think lymph flow is better for you based upon my understanding of what the anatomy is, which is a great point. So we're talking about no option disease, and now we're offering potentially more than one option.
And I would imagine, I mean, there have to be some sort of indications that visually that you could also see if it might be a better case for this trial, or, going and finding someone who already performs lymph flow. Is there a type of wound or place in which this wound exists that would give you a better indication?
No, I don't think it's so much the quality of the wound. I mean, lymph flow is interesting. Lymph flow is both commercially available and available on a post-market surveillance trial. On a post-market surveillance trial, it's very hard to get into that trial because they won't take wounds that are as bad, oh thanks,
Mhm.
as bad as the wounds that Avira will allow, the boomerang trial will allow. But it's not the wound per se. I think that most doctors who are doing this will also have access to lymph flow or
Yeah.
off-the-shelf DVA. So it's not like you have to pick one doctor over another because they do one thing or another. The
Okay.
doctors in this will probably have access to both technologies and be able to help you make those difficult decisions.
And I think I confused, is it Tim? You can go ahead and unmute. I brought up the P tab, so now she's wondering if this could actually be for below the knee and above. The P tab is, or the detour system, is where they hijack a vein, and so instead of a femoral popliteal bypass, which is an invasive bypass where they go from the thigh to the knee, or the thigh to the calf, fem tib bypass, tibial bypass, they can do the PTAB or detour system. This is for people that are on deck for amputation and have basically very little blood flow to the foot, definitely no blood flow to the wound that needs healing. And so this is a targeted therapy, correct, Dr. Runback?
Yeah, the detour is basically above the knee, and this is below the knee. So it's a simple way to think of it, depending on where your blockages might be.
And Marcia has a question. Marcia, you can go ahead and unmute.
Hi, this is fascinating. Thank you, doctor, for joining and telling us about this. So if somebody doesn't live where your centers are located, does that automatically disqualify them? Or like, can they travel? Would you guys pay for travel? How does that work?
Well, yeah, I mean, obviously you have to get there for the evaluation, and then you'd have to get there for the procedure. And there are certain points that are required by FDA to see patients afterwards. Sometimes, depending on what it is, we can work with your local doctor for things like ultrasound, but we would need to see you from time to time. So if you're able to travel, that's perfectly fine. You don't have to live nearby necessarily. Actually, I just treated somebody who came from Rhode Island to New Jersey for me to treat them. So that's not all that uncommon. We had someone.
Because if somebody's like at their last ditch effort, it's this or amputation, they might be willing, if they have help, to travel to wherever you're located.
Yeah, sure. And as for paying to travel, this company has been very accommodating. They really want to make a difference. They actually want to help us make a difference in people's lives. So, for that patient, they assisted in payment, would be on an individual basis. If I said to them, I had a patient coming from, I don't know, middle of Oklahoma, and I don't know why I picked Oklahoma of all places, maybe the wind coming off
The
the
wind comes sweeping down the plain.
right there. Um,
Yeah.
I'd ask them to be willing to sort of support travel. That wouldn't be my decision per se, but the company might. Yeah.
Interesting. Thank you very much.
Yes, and we always help with that, too. If there are patients that are struggling, if they need to get from Oklahoma to go see Dr. Runback. But as you said, Dr. Runback, do you want to kind of run through at least the states in which we do have, we don't have to say the specific centers, but we can maybe give some ideas as to the areas. I know probably, so New Jersey, I would
Yeah.
imagine. I know North Carolina.
Yeah. So I'm gonna actually go on my computer to my right because I don't know where all these things are. So Whittier, I guess that's California, right? Okay. So Portland, Houston, uh, Maryland, uh, Florida, First Coast, I don't know what, Denver, California, and North Carolina so far.
I think I could name the doctors in about half of them.
Right? And let me see, because he actually emailed me or texted me where the CEO of the company. Let's see where the others are going to be. Another is going to be Cornell, which is city. Penn, so that's going to be in obviously Philadelphia. Rush is coming on board, so that's going to be up in Chicago, and Seattle and UCLA. So
Oh,
there's going to be quite a few spots around the country involved in this trial.
and Nancy, it is your doctor. We have a live studio audience for those who are joining on YouTube. So
You.
she is very excited about that. Nancy, you can unmute.
Well, that makes me very happy. And
Mhm.
I don't think right now, I don't need anything like that, but that's great. He's a fantastic doctor. So
Yeah, thank you. That's very kind. It's very kind.
But isn't it interesting, Nancy? I mean, you're far from needing something like this, but you're here, you're watching this. What does it mean to you to hear something like this?
it gives me a lot of hope and takes away some of that fear. I mean, I'm doing everything I can to not let that happen and to stay well, but I also know how much I'm up against with all that I'm going through with LPA, with the cholesterol, with all the things I'm doing and what's happened to me. And I've had a heart attack and I have a defibrillator. So yeah, I mean, I know that, things could happen. It could get worse. It could do it quickly. I'm a diabetic. I could get a wound. So it gives me hope.
And what's pretty incredible about something like this, and I like that new technologies that innovators are targeting that last leg, right? That last mile in a sense. What can prevent that amputation, the amputation that no one else can do anything about? Because we have quite a few patients, Dr. Rundback, that they'll say you won't even survive the anesthetic for an amputation. And if they can't survive the anesthetic, they just leave them and they let their feet rot. I have two patients over in Europe that they're just letting the feet rot because the person has so many other comorbidities that they can't put them completely under to remove the foot. But yet they won't try a deep vein arterialization, something like this, to even at the very least make the patient comfortable, right? Give them a little bit more blood flow, make them a little bit more comfortable. And that's really important. So it's nice to see that this new technology is out there to give patients that final fight in a minimally invasive way with just light sedation. That's what's really key.
And look, we strive every day to be better than we were the day before. I certainly do. That's sort of, I think, an important lesson in life. But unfortunately, there will still be individuals who are not candidates for this. And it may just be tremendous frailty. Although I'm doing one tomorrow on an 88-year-old woman who's very thin and very frail, and I was very hesitant. And her daughter, who actually is a podiatrist, they're also from out of state, said no. Up until this, she was very active in the church, and walking around, and she's frail, but she's strong. She wants to do this. So I think it's an individual assessment, and it's not just a decision that we make alone. We make with the patient, with the patient's family together. So
patient selection is always key with deep vein arterialization, and especially with a trial. Is it literally the same really tough recovery process and healing process as it is for a general DVA, where it's going to get worse before it gets better?
Yeah. So again, I think some of this is more related to the anatomy in which we do this compared to a limb flow. And I said that if the arteries are open down to the lower third of the calf, I prefer this. And I think you've used the terms before, distal DVA versus proximal DVA. Distal means you create the connection in the artery and the vein just arbitrarily more than halfway down the calf, and proximal from the halfway point up. But one nice thing about this is, since they're all distal DVAs, is that DVA storm that you're describing with the pain and the swelling is considerably less. So the recovery is much, much, much quicker. Also, when you do a traditional limb flow DVA, let's say you need to have a transmetatarsal amputation because there's already a lot of gangrene. You have to wait a month and you have to do a guillotine, I hate to take that word, guillotine gangrene, sort of amputation, sort of cut, which is very slow to heal. And the reason for that is because you have so much swelling that you can't close it, because the swelling would, just prevent a good suture line or stitch line. With this, you can do a primary closure with the skin flap, so you get a much better, quicker healing and better cosmetic results. So those are other advantages of this because it's a distal DVA.
Fantastic. Any other questions from the studio audience, or we'll go ahead and I mean, I think that's a good place to stop. We appreciate all your time for being here. If people want to learn more about this trial, Marcia, go ahead and unmute.
Yeah, I had one more question. And I'm having problems here, sorry. My question was, and you might not have an answer since you're still on trials, but what is the, like I have 5 stents and I restenosed, I'm 100% blocked again with great collateral. So I work really hard, but what is the restenosis projection, or like, can it do that just like stents do?
Right. So in DVA in general, at least a third of patients, kind of re-narrow and need kind of surveillance and repeat procedures. I must admit that I've adopted my practice. So anyone I get a DVA on, at 1 month, I do another look, a second look, because I know there's a high rate of re-narrowing, and the trick is to catch it and fix it before it blocks entirely.
Really?
Yeah, and that's made a big difference in our practice. And, I think a lot of this is just telling patients up front that we're going to do this, and if people go into it with the appropriate expectations, it's much easier than after the fact saying, oh, I'm not sure, maybe we better look. So we anticipate that. And I'm doing that even though we're on the trial, even though the trial doesn't demand that. I'm still doing that look at 1 month because I think it's really important. Now,
so at 1 month, what do you do if they're showing signs of narrowing and restenosis?
Yeah, then
do you
we
go
can,
back
at that
in?
point, it's much easier to kind of touch it up and open up narrowing than it is to open up a completely blocked and clotted DVA. It's it's much quicker, it's much easier for the, for patients. So, an ounce of prevention in this case really is worth a pound of cure. So
Thank you.
Fantastic. Thank you so much. Brenda or Marie or Douglas, anyone else have any questions before I wrap up? Okay. Well, go ahead and you're going to get a website up and running, and we'll be able to post that when it is up and running. But in the meantime, you can definitely go to YouTube at youtube.com/at the weight of my heart. Subscribe to our channel. You can put a comment under here that you want to learn more about this, and we'll make sure to message you. You can also email info at padhelp.org, info at padhelp.org, and we'll get you in contact with a doctor that offers this procedure and is involved in the trial nearest you. Thank you so much, Dr. Rundback, for all you do, and I appreciate you taking time out of your busy schedule of saving life and limb to help save life and limb across the